Good afternoon, everyone. My name's Deirdre McGill and I'm the Executive General Manager for the at-home support of Bolton Clarke, and I'd like to welcome you here today. Can someone give me a thumbs up that everyone is okay with hearing my presentation?
All good, thanks Deirdre.
Thank you, that's great. Well, we've heard some fabulous speakers in session one. Very impressive, some great areas that we can all learn from and take away and implement in our practice, as well as learn more broadly what's happening with some research and across the community and sector. Session two is just as exciting, and the session two is in relation to implementing and evaluating an evidence-based holistic whole of community approach to wellbeing. Now, this session is building off session one by exploring the application of the evidence into practice. And we have two presentations followed by a 20-minute facilitated panel discussion. Please add your questions using the comments function so we can incorporate them into the panel discussion. And we start with some of our Bolton Clarke-led work where Ms. Kerry, Rendell and Dr. Rajna Ogrin will be talking about the Connecting Communities to Care Social Connection program. Based on a successful UK social prescribing model called Health Connections MENDIP, a whole of community social connection framework is being co-designed, and the presentation will describe progress to date. This is called Using Evidence-Based to Co-Design, Connecting Communities to Care. Kerry Rendell is a project manager to the Connecting Communities to Care, and Kerry has qualifications over 25 years experience in business and marketing across various industries. Since joining Bolton Clarke late 2015, she's developed and led the implementation of the preventative health initiative Be Healthy and Active, and now holds a dual role as project manager for Connecting Communities to Care. Dr. Rajna Ogrin is a project lead to Connecting Communities to Care. As a podiatrist, Rajna recognised the limited evidence being implemented in practice in health. This led to her PhD and postdoctoral studies in the area of providing best practice care in people with diabetes and older people with wounds. Her research has naturally evolved into developing services and education resources that have been co-designed with community members to improve health outcomes. Her goal is to support delivering evidence-based practice reform in models of care that make measurable change to community members and health professionals' lives. Rajna will start this presentation. Thanks, Rajna. Thanks, Kerry.
Thanks so much, Deirdre. Okay. So today we want to talk about how we've gone about our community-wide social connection approach. And the first session beautifully set the scene for us, so thank you all. And this will be a tag team effort. So I'll pass the next slide on to Kerry. Firstly, actually, I want to mention, please tweet. I've been tweeting away please use the hashtag #SocialConnectionOz to try and disseminate this message more broadly. So thank you, Kerry.
Thank you, Rajna, and thank you, Deirdre. Hopefully that's all. The presentation is up on screen. Great, and thank you everyone for staying with us for session two. Connecting Communities to Care is a study, as Deirdre mentioned, that's modelled on the proven success of social prescribing programs, specifically drawing from Health Connections MENDIP UK, where we had the opportunity to visit and view what they were doing and how they went about it. In addition to that, we have been working on interventions to support older community members to be as well as they can, and a community-wide social connection approach, Connecting Communities to Care, is the culmination of all of this. So this is a 4-year pragmatic mixed methods prospective study, of which we are in the first year of, working with the stakeholders to co-design and then implement and evaluate this social connection approach that uses social prescribing as a key element. It focuses on older community members, specifically within the Glen Ira local government area, And the aim is to optimise holistic wellbeing, taking the World Health Organisation's definition of physical, psychological and social wellbeing. So social prescribing, as defined by the National Alliance of Social Prescribing, is bigger than just prescribing someone a social activity. They define it as supporting people via paid connector roles to make community connections and discover new opportunities, building on individual strengths and preferences to improve health and wellbeing. Social prescribing has 4 components: the individual, who will be having the prescription, the referrer, the connector role that Professor Jane Farmer referred to in the previous session, and then the activities that will be referred to. It is a pathway of relationships to link people to a set of activities for their health and wellbeing. We are wanting social prescribing to form a key part of connecting communities to care, but it isn't all of it, because we want a whole of community approach. And taking the very beautiful words developed by the Social Care Future Movement Group in the UK, we all want a good life. We all want to live in the place we call home with the people and the things we love, in communities where we look out for one another, doing what matters to us. And we know this isn't a pipe dream that we're striving for, as Health Connections Mendip have been able to achieve something like this. So this leads into our project, Connecting Communities to Care, and our team consists of, from Bolton Clarke, myself as the project manager, Dr. Rajna Ogrin, the project lead, Professor Judy Lothian, and research officer Elizabeth Robinson. From Alfred Health, we have Dr. Daniel Feinberg, General Medicine Consultant, Kayleen Fiddies, Manager, Australian Disease Management Association, and Angela Yerolomu, Service Development Manager from the South Eastern Primary Health Network. So Connecting Communities to Care aims to build on what we know of existing programs and evidence so that we can develop something that learns from what others have done, with collation of information to identify the core components to enable this to work. Then working with local people and service providers in co-design to shape the program, and then implement and evaluate, with the end aim of improved wellbeing of older people in the community by activating that community, building an ecosystem where people help each other, linking older community members to existing local supports and facilitating them to build agency and capacity so that they develop supports should existing services not meet their needs. So our co-design methodology entails the active engagement of all stakeholders, drawing on their unique experiences to shape the design of the program. Critical in this process is having the community members at the centre. After all, this is about facilitating their optimal wellbeing. So nothing for them without them, as the UK mantra for social design goes. But then we also need to engage those others who are going to be involved in what is being delivered, which means that we have to take a systems perspective so that we are sure to engage the right people. And thirdly, and very importantly, governance and processes. They don't just happen, and efforts are needed to be made to set these up well. So I'm actually now going to tag Rajna back in to provide more detail about our co-design approach.
Thanks, Kerry. So our Bolton Clarke Research Institute have adapted a number of approaches for co-design and have found that this works for us. And while it looks linear, we know it isn't, but it flows along a forward trajectory of discovering, defining, developing and delivering, where we start with discovering, of building relationships, sharing experiences, gathering insights and information from the literature so that we can understand what works, and then synthesising the findings to identify key areas to address, and then turning ideas into improvements, and finally acting on those ideas to deliver. And today we're talking about the first few steps because we're yet to get to the delivering. Now, one thing, as stated earlier, the governance and processes are really important for the whole program, and we've spent a bit of time developing this governance for the project. We have a steering committee providing oversight, governance and guidance, with key people made up of decision makers from each of the collaborating organisations, as well as including representatives from the Department of Health, Safer Care Victoria, Council on the Ageing and the Ambulance Victoria. We have ethical oversight from the Bolton Clarke Human Research Ethics Committee for this first co-design, and we'll be expanding to other ethics committees as we go to implementation. And then the core project team, which are representatives from the 4 collaborators, which then link off to the working group, which actually take on the activities that have been decided by the core team. We then also have access to a community of practice through the Australian Disease Management Association, where we connect to other initiatives that are underway in social connection and social prescribing, so that we can all learn from each other in a sharing environment. We're undertaking co-design with those key stakeholders drawn from the Glen Ira community, starting off with the older community members, which we're going to be talking about today, but also targeting health and social services, volunteers and funders down the track. And we also have an advisory group for expert advice from key stakeholders, academics, health services, social services, but also making sure that we have community members engaged in that, because everything has to revolve around what matters to those community members, and we're tapping into the Bolton Clarke Community Participation Group. So the research we've done in supporting older community members to optimise wellbeing made us look at what was already out there in the community-wide connections, and Kerry mentioned the Health Connections MINDIP, and that has multiple aspects that they have unpacked to ensure that what they deliver worked. In the community-wide approach. And so raising knowledge and awareness of existing supports in the community is important, building networks and connections between community members to help each other, having paid roles, that connector role that Jane Farmer mentioned, identified, to support those who need help, to link with these supports, and they must be trusted. And then engaging other trusted people like GPs, healthcare providers, who can then formally prescribe social activities and be a trusted link to social supports, but also bridge the gap between the medical and the social care, which we don't really do very well. So using this as a foundation, we reviewed the literature in each of these component areas identified by the UK approach, and we extracted data on the barriers, enablers and outcomes from each of these. We then subgrouped the findings into themes and identified what one of our project officer, Liz Robinson, calls enactables, which I really love the term. It's what works and can be applied into practice. But we also identified what areas need to be worked on with local stakeholders in the co-design, which forms the basis of us working with them. So the 8 core components are the understanding what needs to enable access. Awareness is a big piece, but we've also got to think about accessibility, availability, acceptability, affordability and adequacy. Community assets, what is in that local community? And Jane Farmer's team have done some amazing work unpacking the services in the Glen Ira region, which we are very thankful for. The paid connector role is another important aspect. The intervention itself, that mechanism whereby that connector is enabling, and the other social prescribing component fits and enables that support to access the social connection activities. And then Jane also mentioned social capital. So that's that value that can be gained by those connections between people in the community. We do also need to consider the feedback and evaluation, information sharing, so that everybody knows what's going on and are brought along that journey and are wanting to engage to make things continue to be improving. Volunteers may play a big role in those social services and supports, but also they might need to take on an additional role of supporting people to connect from accessing those services. Supports might need that little bit of extra help. And funding is the perennial difficulty. How can we continue to deliver something sustainably and feasibly? Who's going to pay for that ongoing? So that's all well and good to have those core components, but we need to figure out what that looks like on the ground. And so we just, in simple terms, people need to know about it so that they can know they need to access it, or that it's there in the community. They then need to reach out to and connect with the front face of this Connecting Communities to Care, the connector role, and then develop rapport to find out what matters to those older community members that have sought that interaction. Then next step is developing goals and plans to achieve the goals to enable that connection. Then the linking to those supports and following up to make sure that there has been a positive difference and evaluating that. And whilst that looks so simple, we know that all of this is has a back-end work that needs to be considered to enable the service to work. And I know this looks like a busy slide, but it just illustrates all of what's involved. We know that someone who has social care needs, they need to perceive they actually have a need and that the service is approachable for them. They need the ability to be able to seek the program, but the program needs to be acceptable to them and they need to want to take part in it. They need to have an ability to reach the program or the front face. It needs to be available and be able to accommodate them. They need to have the ability to pay for it. So it needs to be affordable and they need to have the ability to engage. It needs to be appropriate for them. So we need to ensure that all of these things happen, which leads us to co-design. We need to work with those who will be involved in this program. And last year, we sent out a call to action asking local older community members for their help to build a network to connect in their area. And the message was shaped with our community partnership group at Bolton Clarke. And we asked our networks to share widely, including the council, services who have community networks and our own networks. Because of COVID, we started with those who were able to engage online with a view to having face-to-face once restrictions eased. And coordinating co-design is, as always, an exciting adventure, but we did manage to get 3 people online at one time. So we first, in this first session, we wanted to make sure that the concept of having someone linking people to local supports was valid and what they thought would be needed in this context in Australia, in Glenara. So we used a persona, a fictional person who embodied characteristics that were common. And we know that people find it easier to talk about others rather than themselves. And so we used Jan, who was a recently widowed person who wanted to stay in her own home and keep independent, but was really struggling. So we didn't want to shape how our community members thought about this. We wanted to let them come up with their ideas of how they thought this needed to be addressed. And they brought up multiple supports, and that linking to local supports using some sort of connector role would be incredibly helpful. But they also unpacked all of the other bits and pieces that we intuitively knew needed to happen and was articulated in the literature, but these guys actually formalised and contributed their knowledge and experiences and thoughts around this. So that was really, really comforting for us. So we had a second session that was hybrid. 2 of us were in the office and 4 were online, and we brought in the awareness piece of how can we engage people in a way that is welcoming and would increase the likelihood of engaging. And we showed examples of other messaging and asked their thoughts on what would work for them. And so we also asked their input on selecting a logo, and we used an online logo tournament to generate ideas and shared a short list of concepts with them, which you can see here. And so this is the next. And what we found, or the next step, was that the group identified that the message needed to be framed positively. Not too much information to be shared at this time, it becomes overwhelming. But also people needed to know that any information that they shared would be kept confidential. And beautifully, and as always happens, at the same time that we were doing this, the South East Melbourne PCP actually developed a framing age document which guided around how we communicate with community members that is a positive and respectful way. And so this group also then helped with the selection process of the logo, and that's why we got this Connecting Communities to Care logo here shown through the presentation. And then the final presentation, that was around exploring the user experience using Beth as our persona. And we wanted to go through how people call in, because we know that so many people have been scammed in the past. So trust is incredibly important. Would a 1-800 number be trustworthy? You know, what about a landline? You know, how would we need to engage with someone so that they would be comfortable to be able to talk with them, to encourage people to share information about themselves. And so this was where they were very clear. It was so adorable for us. We developed a beautiful spiel on sharing information about what we thought would happen, and they were all laughing at us about, no, it needs to be short and it needs to be all about what the person needs and what the program can do for them. But it's also about needing to take time to build trust and rapport by phone first and foremost. And that might take a few goes, and it might take a few phone calls for someone to feel comfortable enough, but you need to enable meeting when the person is ready in a neutral place, in things like a local library. And there's new initiatives called chatty cafes, which are in safe, open spaces where people can come together to talk, and further discussions about what would work for them can be had. So we're now building further to shape the service, develop the service structure, shape the website and shape the service directory. So we will keep everybody in the loop in terms of our next steps, and we hope to start in the second half of this year. So I'd like to give our emails, and we will have a discussion at the end of this. Thank you.
Thank you, Rajna and Kerry, for your fabulous presentation. It's a fantastic opportunity, and we're at the entry point with the Connecting Communities to Care project, but we're eagerly awaiting some great outcomes and demonstration of the differences that can be made with your premises. Now, I just want to advise you